Hello, everybody. Welcome to Strategies of Managing Myopia, a closer look at this growing epidemic from Excel Specialty Contacts, the makers of the new rim lens orthokeratology lens. I'm Dr. Nicholas McColley. I practice just outside of Indianapolis, Indiana. And today we'll be talking about orthokeratology as an overview, what makes the rim lens different, and a case study from my experience with the rim lens. So, moving to what is orthokeratology or Ortho-k. As many of us know, it's the compression of the central cornea overnight with a gas perm lens to reduce the corneal steepness in an effort to reduce realized myopia for our patients during waking hours. So why should we do it? There's a couple of reasons. One is refractive correction. All patients like to see clearly, and this is one way to accomplish that without wearing glasses during the day or contacts during the day. For many people, it's a good alternative to refractive surgery if they're not a good candidate for LASIK. In children, it's also been shown to slow myopia progression, through the means of myopia prevention, as many of us are aware, and there's a growing movement in optometry to help in this field. So the rim lens is built on the Boston Orthokeratology VST design vision shaping treatment. It has the same parameters of FDA approval as VST systems do, with a couple of differences. It has a couple different diameter options and a couple different optic zone options. We'll talk about why this is important and how it could be applied with the rim lens. The lenses themselves are made from Boston Equilens 2 material, has a DK of 85. It's FDA approved for daily wear, extended wear, and overnight Ortho-k use. You can have red and yellow buttons, and this helps to differentiate between which lens goes in which eye. Usually we do red for right, left for yellow, and this helps the patient distinguish which one should go in which eye. And obviously it doesn't matter exactly the color that it is because the patient won't be wearing these during the day. So what is the process of myopia management or myopia prevention? And it's to create peripheral defocus to slow the axial elongation. As we know with myopia, the eye grows during our adolescent years, and that creates more myopia over time. From Bollamore and Brennan, 1 diopter of successful myopia management results in a 40% drop in myopic maculopathy. So every advancing 1 diopter increases your chance of myopic maculopathy by 67%. So we all know that longer eyes have more problems. They have more cataracts, retinal detachments, myopic maculopathy, glaucoma. Over on the bottom right here, you're going to see an odds ratio table, which basically tells us the increasing risk of these conditions happening with and how it's correlated to refractive error. And as we can see, each bucket, there's a substantial increase in each of these problems. So there's a lot of different proposed mechanisms for why eyes grow during our adolescent years and about how to fix this and what exactly is going on with Ortho-k. So some people believe in this model where uncorrected myopia, obviously light focuses in front of the retina, and when we correct it with traditional means, only the fovea is fully landing on the retina. With myopia prevention, the goal of many techniques are to increase the peripheral arc of that light in front of the retina to stop the signal for the eye to grow to catch up to that light ray. There have been other theories proposed, but this is one of the more prevalent ones. And how exactly does orthokeratology work in terms of a physical application? So again, there are various theories, but what we can see is that there are morphological changes to the central cornea, and the central cornea becomes thinner, where mid-peripheral cornea becomes a little bit thicker, and it collects cells or at least intracellular fluid to pull the central thickness down. So this is a complicated thing. Why implement it in your practice? Well, first off, our job as physicians is to make the best lives possible for our patients. And by preventing future effects down the line from having elongated eyes, we can improve the quality of life for our patients. There's a growing awareness from other practitioners and parents, so this is a growing field, and it's going to help you stay competitive in your market. It's a consistent revenue stream because insurance isn't involved, and patients can kind of understand that this is something to help their kids see better and to have them be healthy in the long run, and so they're more willing to pay in cash. And the absolute worst thing that can happen is when a patient comes in and they ask me, why wasn't I told about this technique before? And the reason that's bad for a practice is because what it means is even if they leave my practice, they're never going back to the practitioner they saw before because they weren't even given the option. And so it's always good to present all options so your patients are aware, and they don't ask that question the next time they go see somebody, well, why wasn't I told about this before? Because then you lose trust and loyalty. And trust and loyalty is what we try to build in our practices. So how do we choose an Ortho-k design? Because there are a lot of them out there now. It kind of depends on where you are in your practice and how you're currently fitting lenses. If you're fitting them empirically with a topographer, Ks, and refraction, or if you need a dispensing set on hand. It depends on the equipment available to you, chair time, staff time. And so today we're going to talk about why the rim lens can work well in really any model. It can be fit empirically. It's customizable. The consultants are very easy to work with and knowledgeable. It's easy to reorder. And there's even an online calculator now that we can use to order. Another reason is it's more flexible in terms of how we fit patients. So the first thing that we're going to do is decide what diameter of lens that we want. As you can see here, it's based on visible iris diameter, VID, or if you have it, HVID, and it can tell you what lens to start with. Generally, most patients are going to fall in the 10.6 millimeter lens diameter, but we can go larger if we need to or smaller if we need to. The lens optic zone is also customizable in the rim lens, which is important because optic zone can be kind of a double-edged sword. If it's too small, you can get flare, glare, and halos because the edge of the pupil is touching that reservoir zone. Or what we've found out from a few recent studies, including the one cited at the bottom of the slide here, is that if your optic zone is too large, the effect of myopia management is not as great. So actually having a smaller optic zone diameter can improve your myopia management. So it depends on your goal. If you have somebody that you're just trying to improve their refractive technique, you want a larger optic zone. That way they don't get the distortions and aberrations. If you're working with a kid where you're trying to prevent myopia from increasing, maybe you go with a smaller optic zone. They may have more spherical aberrations and a loss in contrast sensitivity, but the VA is going to be similar to what it was pre-treatment with glasses or contacts. And so that's important because it's another way to better control myopia management. The fitting zones in the rim lens, there's the treatment zone centrally, which touches the cornea and compresses the central cornea. There's the reservoir zone that collects the intracellular fluid. The stabilization zone, which makes contact with the cornea again and helps to center that lens. And then the dynamic edge profile. And we'll talk about those in detail here. So the treatment zone here, this is the center ring that shows compression on fluorescein installation. So there's no pooling of fluorescein in the middle with a good fit. You're looking for 4 to 6 millimeters of treatment here. So with the, sorry about that. With the treatment zone, the base curve remains constant. We're not changing the base curve as a fit function. It's more of a treatment function. So the reservoir zone here usually has 0.5 to 1 millimeters of pooling of fluorescein in a well-fit lens. It's 3 to 5 or more diopters steeper than the back optic zone, and it forms an annulus-shaped tear reservoir surrounding the central flat zone, inducing negative pressure. It collects epithelial cells and intracellular fluid, like we said, to help with that central treatment zone. The stabilization zone here is the first zone that we come to that's actually a fit function of the lens. It's going to bear on the cornea, and it's supposed to align with the peripheral cornea or the mid-peripheral cornea to get good centration while still allowing for movement. Manipulation of this zone is independent of the other zones and can be utilized for the treatment as well. And here is what really sets Excel apart and the rim lens apart from other Ortho-k designs. We have the dynamic edge profile. The dynamic edge profile is independent of all other curves. It's going to be manipulated. You can manipulate it whether you use a 10/6 diameter, higher, lower, smaller, bigger. We can always change the edge lift here. And that's important because sometimes if we're getting too much suction and compression overnight, we can lift the edge lift to allow for more movement so that it's not so hard to remove in the morning and uncomfortable. Or if we're getting too much movement, we can steepen it to try to center the lens better and make it more comfortable. So when fitting the rim lens, what do you need? Well, the first thing is you have to have a topographer, one that ideally measures the VID so you can start with the correct diameter, the eccentricity, and offers difference maps and axial length measurements. And these are important because the difference map helps us decide if we need a back toric lens to help with centration, or if we need different techniques that way. The other thing that we need here is an autorefractor and a manual keratometer, and we need this separate from the topographer. And the reason is that the SIM-Ks that come from a topographer sometimes aren't as accurate as a traditional keratometer. So for K readings, we actually prefer an autorefractor or manual keratometer. You'll need fluorescein dye, obviously, a Ratten filter to help judge the pattern of the lens on the eye, and then your general GP removal tools and care tools. For practitioner training, Excel provides a wealth of knowledge on all of this. There's extremely concise troubleshooting guides that not only present a problem, but detail very specific solutions to those problems. And they also have a great consultation team that can walk you through the process. When you talk to a consultant, you're going to need a few things. You're going to need an over-refraction. And again, that's a refraction that is over the lenses on the eye. A lot of times as optometrists, we think, oh, after treatment, what's the over-refraction? In this case, an over-refraction is still contact lenses on the eye. What's the refraction over the top of it? The manifest refraction is considered the refraction after treatment. And so they're going to need the manifest refraction without the lenses and the time of the day that that was performed, because that obviously will impact the results. If you do it in the morning right after they take the lenses out, it's going to be different than in the afternoon, and thus they've stabilized in that lens. If you have topography, that would be great, and a picture or description of the lens centration and how it looked under the slit lamp. So then how do you train your staff? And how do you screen candidates? I'll say that staff training and staff communication to patients is one of the most important things while fitting any specialty product, not just Ortho-k. I make all of my staff members try these different lenses and treatments so that they understand the process firsthand and can relate it to patients. And I sometimes even fit my staff members permanently in these products and then allow them to take the head on teaching other people how to do it, or to start that conversation initially with parents or with the patient. Your techs also need to be able to reliably get topographical data and report that to you in a concise manner. What I recommend is taking the time, take a half day, take a day out of clinic, probably don't need a whole day, probably just a half day, go through this process with them, show them what they need to get on your topographer, show them how to take care of the lenses, get them in and out. That time that you take out of clinic, or even if you do it after hours, it's going to pay back countless amounts. Huge return on investment here, because they won't look at you like a deer in headlights when you ask them to help you with this. You won't have to do it yourself, because we all know that the most important time in terms of the most important function of the practice is doctor time. And if we can reduce the doctor time on these patients, then that is beneficial for everybody. Your staff also needs to understand the pricing and policies of the company. Rimlands makes it easy with prices and warranties. Really, Excel overall as an entire company does a great job with this. They'll give you prices for warranted and unwarranted lenses. There's a remake period that is very gracious. There's a few different pricing strategies for these lenses. You can do a la carte pricing. So you have a line item for the fit for each material, and you go from there. You could also do package pricing, and that can be paid one time up front. It can be paid monthly as a subscription. You need to find one that works for you. And then you can also have maintenance plan pricing so that the cost goes down after the initial fit. As with any major procedure in the office or change, I would recommend having a consent form, which an overview of what Ortho-k is, alternatives and contraindications, limitations. Not every Ortho-k patient is going to see 20/20, and that's okay as long as they're functional. Talk about the risks, fees, and discontinuation policy is very important to have that concisely spelled out for patients to understand, so that if there's an issue with that later on, they can just refer to that. Other forms, you can talk to medical professionals in your area, ask for referrals. A lot of other specialties don't know that this is something that can help patients. And so talk to pediatricians, talk to school nurses, talk to ophthalmologists that are OD friendly, and even retinal specialists that see myopia, the pitfalls of myopia long term, and say that you can help patients by doing this. You always need something in the office for patient and parent education. When you talk to parents, you need to explain a lot about what's going on, starting with, are they myopic? Do they understand what is going on? Do they know the risks? Most parents don't know the risk of myopia long-term for their kids. You want to talk about the change since the last visit. You can pull up calculators that show age-based norms and what the likely progression is with and without treatment. And it's always good to have brochures and pricing handy to give parents a little bit of time to think about it and read some more material over the subject. So how do you do an Ortho-k fit in your office? Well, in my office, what I usually do is it starts with a comprehensive exam. At the comprehensive exam, I look at it, I present it as an option if it's refractive, or I discuss the change since last time if we're talking about myopia prevention, and what we would need to do in order to help slow it down. At that time, if the parents or the patient are interested in moving forward with Ortho-k, really the only extra step you need is a topographer. So sometimes I'll ask for a topography going out the door. If you're worried about the child not being able to get the contacts in, or being uncomfortable, or dropping out because of any other issue, sometimes we'll throw a contact lens on the eye just to show them kind of what it'll feel like if we have time in the office. But other than that, unaided VA, manifest refraction, corneal and ocular assessment, you're doing those anyway at the comprehensive exam. So then you go and order the lens, and the lens comes in, and how do you handle it from there? Well, we schedule a time for a dispensing visit. At that time, we do an insertion removal training. Sometimes we'll give some anesthesia to help with the initial shock of the lens on the eye. We'll let them sit for about 10 or 15 minutes with their eyes closed, and then we'll do an over-refraction, a corneal and ocular assessment, and see how they're doing. Make sure that this is something that's going to work for them, that this is a good, healthy lens to start with. On subsequent follow-ups, you'll do a topography, manifest refraction, over-refraction, VAs, corneal assessment. But notice here that on the dispensing visit, they come in, they learn how to get the lenses in and out, over-refraction or an auto-refraction, and they wait a few minutes and then I come in. That dispensing visit, it's no more than 5 to 10 minutes of doctor time unless there's a lot of questions from the parents. But your staff should be doing everything else. They should be doing education. They should be doing all the other steps. So for a typical follow-up schedule, what we'll do is we'll dispense the lens. We'll have them come back the following morning or maybe 2 mornings and wear the lenses in if possible. Sometimes that's uncomfortable for the patients, but if they can wear them in, that's really the best case scenario. So we can see them on the eye after they've been sitting there all night. Then we'll do the assessment over refraction. We'll take them off. We'll see how they're doing. If everything's looking good at that point, we'll do a 1-week follow-up. And if everything's looking good there, we'll do a 1-month follow-up. After the 1-month follow-up, as long as everything's going well, we usually do a 3-month follow-up because that's proper time for the warranty in case we need to make any final changes. And then we'll go back to 6-month to yearly checkups. Obviously, if things are not that smooth, you need to adjust that schedule. And in my case study later on, we'll talk about that. Actually, it's starting right now. So this is a case study of a 9-year-old that I fit in orthokeratology lenses, the rim lens. She's a 9-year-old Hispanic female. She's a competitive gymnast. And when they told me at first that she was a competitive gymnast, I kind of thought, oh yeah, that's normal. Apparently they're very serious about this. And she's in the gym 6 to 8 hours a day. They homeschool her. She's hoping to go to the Olympics someday. So she's always in a dusty environment, and the stereo vision is of the utmost importance because she's landing on a very narrow beam or, trying to swing from bar to bar, and you have to have good vision, good depth perception for that. So in 2019, at 8 years old, I saw her, and you can see her cyclorefraction there. And then in 2020, I got a manifest refraction that you see down there below. So she'd switched almost 2 diopters more myopic in 1 year. And I didn't believe it. And so I cycloed her and same thing happened. Uncorrected VAs matched and cyclorefraction yielded the same refraction as the manifest. And if you look over there on the right, her family history. So her dad was a high myope and her mother was moderate myope. And you'd think, oh, this is a slam dunk. I'll be able to talk them into Ortho-k, no problem, because it's the best for them. They know the pitfalls. Well, actually, the opposite was the case, because even though the parents had very high amounts of myopia, they thought, hey, I've got glasses and contacts, and I'm doing fine. I'm no issues. I've never had any issues, and my life isn't any worse off than somebody that's -2, is kind of the way they looked at it. But they're in their 30s and they're young and healthy, and that doesn't mean that they're always going to be fine in terms of ocular health. Things could change the next 3 decades even for them. And so it actually took quite a bit of time and showing some studies actually of the potential risks of becoming more myopic. So finally we got on board because they didn't want her wearing soft contact lenses in the gym, getting chalk and everything in them, and obviously she can't wear glasses. And they were starting to get concerned about potential long-term issues. So this is her topography day 1 before fitting, and sorry about the blurry images. My topographer is about on its last leg. But what's important to note here is that I actually used the Ks that came from my autorefractor rather than the sim Ks from the topographer. And they did not match exactly. They weren't super far off, but it's an important distinction because sometimes topographers kind of miss the mark centrally there, depending on how the eye is aligned. So the first order here, we actually did green and blue to start. This is another color scheme that a few practices use. And you can remember green on the right, blue on the left because of the second letter of each of those colors tells you which eye goes in. So R for right and green. In orthokeratology, we shoot between plano and +75 over refraction. If we look back, she actually had a pretty big HVID, 12.4. But she's 9 years old. She had small fissures. We were a little bit worried about the lens in the eye and the size of it anyway. And so we decided to stay with the 10.6 diameter. And the rest of the parameters there you can see. So at the 1-day follow-up, patient and parents are happy, great compliance overnight. She slept well. She didn't really have any problems with them. We did give her kind of a diluted anesthetic to use to put in before she put them in at night. And that worked pretty well. She woke up in the morning and felt fine. So in the morning of day 1, her overrefraction was plus a quarter. She was 20/20, very happy, right eye, left eye, both 20/20. We did a 1-week check, and then about 3 o'clock in the afternoon, the same thing was true, and they reported increasing clear vision throughout the day during that week. She had good comfort and vision. She was doing great with the insertion removal all by herself, didn't need any help from parents. When I looked at the lenses on the eye, they had acceptable movement and central compression with slight inferior nasal decentration. So this is her topography and the fit week 1. And you can see here that we're starting to get that nice Ortho-k textbook red ring around the outside on the axial curve and kind of the central compression there that's becoming more and more flat. The lens here looks like it's riding high, but I think the lid got it right before this picture, but really it was decentering down a little bit. So I thought we were good for a 1-month follow-up, but at about 2 weeks, the parents called me and said, hey, vision's still good, but the lenses are uncomfortable. She has to put them in and take them out 3 or 4 times before she can get them tucked under the lids right and feel comfortable to go to sleep in. So I said, you know what, come on in. And so at 2 weeks after dispensing the lenses, we looked at them, and the lenses were way more inferior and more nasal. And you can see there, we even got a little bubble in the inferior reservoir zone. And here, the fitting relationship, I think, changed. I think the flatter cornea centered that lens a little bit differently. And she was starting to put that lens onto a flatter cornea because the flatness of the cornea was lasting all day. So then we just needed to make a few tweaks. And so I called the Excel consultants, and, you know, because of the rim lens unique design, I was able to get more customized lens without changing that central zone, right? Because the central zone was doing great. She had fantastic vision, and she was very happy with that. And I didn't want to adjust anything that could make that change. So the nice thing about the rim lenses with the stabilization zone, we made it a little bit steeper to center that lens up a little bit more. And we also steepened the dynamic edge profile just a little bit to make it a little bit more steep in relation to the cornea and hopefully still allow movement overnight. And again, all of these are independent of the treatment zone and the base curve. So with the 1-week follow-up, this is her topography, and that right eye, it looks absolutely textbook. And she's 20/15, right eye, left eye. I actually think that topography for the left eye was how she was positioned in the topographer, because the fit looked about the same between both of them. It looked phenomenal. At 6 months follow-ups, which would have been June of this year, the refraction without the lenses in, but not with a washout period, meaning she'd been wearing the lenses consistently. The refraction was still, you know, plus a quarter, 20/15. The over-refraction was still plus 75. Some practitioners I've heard will do a washout period before they see them for a comprehensive check, just to see where the myopia prevention has taken effect or if they've had any change. I prefer not to do that. If you're that concerned about that, you know, there's a couple different ways to look at it. You can look at it at the over-refraction to see if that's changed, or you can measure axial length if your topographer has that capability. This 9-year-old was so consistent with wearing them and got such good compression and lasting compression that she actually stopped wearing them Friday and Saturday nights and was still having, you know, decent vision by Sunday evening. And so they were very happy with that. And because of her success, they now want to start their younger daughter on this process soon. She's about 7, and they've also referred other people from the gym, but not just for Ortho-k, for other things, for routine eye exams and other contacts and glasses solutions. I think once you present a specialty thing like this, they understand that you can do this, but you also have unique solutions for other patients as well. So what can Ortho-k mean for your practice? It means healthier eyes that grow with your practice, increased loyalty. Anytime you do a specialty service, it is increased loyalty because they know that they either can't get this specialty somewhere else, or if they go somewhere else, they're probably going to have to start from scratch. And so they would prefer to stay with somebody that knows their history and their case. It's going to mean an increase in revenue. Ortho-k lenses aren't inherently expensive. Your cost, what's expensive is your chair time. And so you're charging patients for your chair time, which means your profit margin is fantastic. A lot of times it's better than soft lenses, especially soft lenses that try to correct for myopia management. Increasing customer base, like we talked about, and it's an opportunity to sell other products. Anytime you have kids and parents coming in your office, it's more opportunities to look at regular glasses, sunglasses. I always encourage all of my kiddos to wear sunglasses because, as we know, UV damage, most of it happens in our adolescent years, actually. So what is the Excel difference? They have a great leading consultation team with NCLE certified consultants with over 200 years of experience between them. They're spread out throughout the United States, so they have very great flexible hours, 8 a.m. Eastern to 8:30 p.m. Eastern, Monday through Friday, which is pretty incredible. You can also leave messages if you need to. Doctor-friendly pricing, it's simplified pricing. You don't need to send lenses back. They automatically credit your account when they do an exchange, and it makes it really easy. It's a same day or next day turnaround on all GP and soft lens designs. I personally went and saw their facilities, and they're incredibly well-designed, efficient systems. You also have a 90 to 120-day full warranty and full cancellation on all custom contact lens designs. The other rim lens unique thing is that it has a very specific laser edging model. Here from this lens, we can tell a lot of information. At the very top there, you can tell what the treatment zone is. It's a base curve of an A4. You can tell what the reservoir zone is, stabilization zone, dynamic edge, and toric factors. And again, that toric factor can be huge if you have somebody with a large micron difference from one meridian to the other on the cornea to help align that lens better. And if you have questions about that, consultants can look at those topographies with the elevation map and really help you out starting there. We also have the lens selection calculator here. So it automatically calculates in the additional 0.75 of power as a regression factor for the change throughout the day, and puts all the other parameters in there for you. You just put in your Ks, your refraction, your HVID, your eccentricity, and your pupil diameter. And from that, it'll calculate a lens for you. So a lot of the questions that I get from patients finishing up here are, is it safe? How long will my child utilize myopia control? How often will they wear the lenses? How quickly will their vision become clear? What happens if we lose or break our device? So is it safe? Yes, it's very low incidence of microbial keratitis. It's just as safe as any other lens that we've seen. It's very comparable, and educate, educate, educate. If there's problems with the comfort or the vision, come see me. That's what I always tell patients. And if they do that, it's very unlikely that we'll have any issues. How long will my child have to utilize myopia control? So this depends, right? We know that some people change and they stop at 16, but other people change all the way through their mid-20s, especially if they're in a professional or graduate program. So it kind of depends on the patient. What we usually tell patients is we like at least through 18, but sometimes progression can continue through that. At 18, we hit a very different part of life for a lot of kids. They either go to college or start working and their habits change. College kids don't sleep as much. So I have some people drop out in college and go to regular glasses or contacts, but I have some people that are in their 30s still wearing these, even 40s, because they love them so much. In fact, I just fit one of my good friends in these. He was not a candidate for LASIK. He was drying out in daily total 1 contacts after 6 hours. No other lens was working for him. And so I said, hey, why don't we try this? And he loves them. He wears them every night. He doesn't have any contacts throughout the day. He can see perfect. and he doesn't have any discomfort like he did. So it really depends on the patient and how long they want to continue with the lens. How often do they have to wear it? This one is very individual as well. Like I said, my case study, she could skip a couple nights in a row and do fine. My friend that I just fit, he can't skip a night. If he skips a night at 11 a.m. the next day, he's telling that his vision isn't as clear anymore. So again, it's very patient specific. How quickly will their vision become clear? So what we generally tell people is 2 to 4 weeks. That buys us a little time. A lot of times it's quicker than that. Most of the time it's quicker than that. But it does buy us a little bit of time in case the fit isn't quite right. And it also sets expectations. You know, the next morning it may not be perfect. Well, as long as we're seeing improvement throughout the time of wearing the lenses, we'll continue to do better. And one comment I'll make about this is try to, if you're seeing improvement at every visit, don't abandon that lens yet, because we're still making progress. Once progress stalls, then you may have to change the lens and change the fit of the lens or the treatment zone to better accommodate the patient. But a lot of times if you switch too early, you'll make a few mistakes and end up closer to where you began. What happens if we lose or break a device? There's a couple different ways to handle this. We build it into our package. Once we're done with the final fit, we order a second pair of lenses for the patients at a reduced cost to us, and it's included in their package. And we do this so that they have an extra lens because it's likely the kid is going to lose or break one at some point. And also we give them very transparent pricing on replacement lenses should they ever need one. And just for your information, in our practice, we package the pricing up front. We kind of compare it to braces. We allow patients to use care credit or sunbit to spread out the payments a little bit, but that first initial visit is pretty high so that we capture most of our costs up front. And then moving forward, the lenses become cheaper as the years go by, as we're just making small tweaks to them, because again, they're paying for chair time, and chair time should become less as you go forward. So I hope you enjoyed the webinar. If you have any questions, you can reach out to me or Excel. I hope you have a great time fitting the rim lens. It's been fantastic in our practice, and I look forward to using it more. Happy fitting. Bye.